A couple of weeks ago, when we inaugurated our own in-house Grand Round series at Cedars-Sinai, we were worried that we would get a low turnout. And so I decided to become an instant expert on a new topic, and that was COVID-19. And since then, I've kept up with it. We just had a review paper published in Circulation Research a week ago. You know, it's something that everybody wants to know about. So I'll do my best to summarize what we know about this and also about how it affects the cardiovascular system. Now, one thing that's quite notable is the fact that the number of publications, if you just look at PubMed, so these are things that are that have been peer reviewed by and large and are in legitimate journals, going from the first citation of COVID plus heart that appeared on February 18th to yesterday, there's 112 papers in that brief period. And if you just more broadly look at COVID and recognize that that wasn't even named by the World Health Organization until the end of January, there's now 3,274 citations. If you also include preprints in preprint servers like bioRxiv and medRxiv, it's really even more of an explosion because these sites have become all the more legitimate in the era of COVID as means of getting the news out quickly whenever there's you know, a new clinical trial or a new science result. So really, almost every day we have to look at the literature and make sure that what we're saying is still accurate. And we've done that. I've done that this morning to try to be current. In looking at the stages of the disease, and this is important pathophysiologically because it may inform the way we approach treatment. The first stage is dominated by a systemic response to the virus, as with many other viral illnesses. And one of the earliest laboratory signs that occurs is lymphocytopenia. I'll get more into that later. The second stage is dominated really by this acute respiratory distress syndrome. These are in patients that manifest the disease critically. This is when by chest CT one sees the typical ground glass appearances, and in chest X-ray you see a bilateral severe pneumonia. And then it goes on to be a situation that's actually dominated by friendly fire of the immune system against self and the host response. And basically what one sees is elevated inflammatory markers and cardiac biomarkers. And in this phase of the illness, one basically sees cytokine storm and hyperinflammatory syndrome. Well, what about the illness itself? What can I tell you that might not be apparent from just reading the news every day? I found this paper, this epidemiology paper published a couple weeks ago in Nature Medicine to be fairly informative. First of all, in the left-hand panel here, you can see that the x-axis plots the R0, or the basic reproduction number. This basically tells you that for any given case, any given proband, how many on average people are infected by that proband. And then on the y-axis is the case fatality rate. So if the situation were one in which the basic reproduction number were 1 or less, which is of course the goal of current social isolation means, then the epidemic eventually extinguishes. The other thing that can extinguish an epidemic really quickly is a huge mortality. So for example, Ebola with 50% mortality is so lethal that the virus can't be sneaky and getting around, and the cases are ascertained readily and can be isolated, and the epidemic can be controlled by fairly routine public health measures. If you look at COVID-19, its R0 is somewhere between that of the seasonal flu and the 1908 pandemic in the 2 to 2.5 range. Its case fatality rate is lower than that of the SARS epidemic of 2002 and 2003, of a very closely related coronavirus. But basically, it's this low case fatality rate that makes it a perfect recipe for a pandemic, because it's innocuous enough that sometimes you don't even notice that it's there, but it's quite contagious. Another interesting thing about the epidemiology is that the symptomatic case fatality risk by age, meaning of those who are symptomatic, how many end up dying. You can see that this really doesn't take off until the 6th decade of life. And then in the 80s, it approaches 6 or 7%. This is one notable feature, but the right-hand panel tells us something even more biologically interesting, and that is that by the 3rd decade of life, there's already an increase in symptomatology. So this is, of the people who are infected, how many actually show symptoms? And this is all normalized relative to the 4th decade of life. You already see that in the 3rd decade of life, there's symptoms, and it's a monotonic increase until old age. So even before the cases become fatal, they become symptomatic. And this is probably telling us something about the biology of adaptive immunity over lifespan and how that then translates to symptomatology and case fatality. If you look at these data, and that's pretty much everything else that's come out since then, the actual probability of dying after developing symptoms with COVID-19 is only about 1.4%, which is much lower than the crude confirmed case fatality risk. We tend to only test, at least here in the United States so far, test only people who are flagrantly showing symptoms, and then even sometimes not. So we vastly overestimate the mortality as a fraction of diagnosed cases. If you include some asymptomatic cases, which may be as many as 25 or 30% of cases, the overall mortality risk, of course, is even lower. So what about COVID-19 and the heart? The first thing that we're going to review today is the realization that immuno-reaction actually kills people. And the angiotensin converting enzyme 2, well-known molecule to us in the cardiovascular system, binds the SARS-CoV-2 virus, but its role in COVID-19 is otherwise pretty vague. Cardiac involvement is prominent. In terms of therapeutics, there's a lot of pseudoscience, hype, and wishful thinking, and unfortunately, so far, these traits tend to dominate the field, and there's little by way of evidence-based medicine. And finally, just acknowledging the fact that there may be long-term sequelae. So in the first point, immuno-reaction, one of the first things that occurs is lymphocytopenia and T-cell depletion. And here you can see in a couple of the studies from the Wuhan epidemic that patient, and this is retrospectively assigned to non-survivors and survivors, the overall white count in survivors is fairly normal or low, which is not atypical of viral illnesses. But the non-survivors later in the course of the disease, 1 week or so after the disease onset, tend to develop a granulocytosis. But meanwhile, lymphocytes are quite depressed in the non-survivors. They're also depressed in the survivors, but much less so. And if you look at another study that was also from China, you can see that again, in this study, the lymphocyte count distinguishes the non-survivors from the survivors. Not so much very early in the illness, but certainly the way that they trend over time is different. And those who don't recover from lymphocytopenia tend to have a very poor outcome. At least some of this lymphocytopenia appears to be due to infection of T cells. At least this is based on what we know about the biology of the SARS-CoV virus, which was the one culpable for the 2002-2003 epidemic. And because that one's been around for a lot longer, there's of course much more basic biology on it. There's not that much of it, but there's much more than there is so far for the COVID-related virus. And here, just on the basis of electron micrographs, you can see inclusion bodies that represent clusters of viruses or individual virions within white cells. And if you look at how frequently such inclusion bodies are found within different kinds of white cells, they're found in all granulocytes and monocytes and lymphocytes, but only in 3% of the cases in granulocytes. Monocytes maybe 30%, and a little bit more than 50% in lymphocytes. So lymphocytes seem to have a predilection for infection over other blood cell types. And this is also borne out in measurements of the clinical course during a lifetime, and that's a depression of total T cells, and this is particularly notable for the helper T cell population, the CD4 positive cells. What about systemic inflammation and cytokine storm? Well, these are genuine and associated with increased mortality. IL-6, for example, is elevated in many cases of COVID, but the cases in which IL-6 goes up and up and up tend to be a very bad prognostic feature, and those in which IL-6 remains relatively low are associated with survival. Likewise, another very non-specific biomarker of inflammation, ferritin, seems to segregate nicely between survivors and non-survivors. And then in another study, something very similar, C-reactive protein, another quite non-specific marker of systemic inflammation, is elevated in patients who were died as opposed to patients who were discharged from the hospital alive. And interleukin-6, again, an association with mortality. What about this whole story of the angiotensin-converting enzyme 2? I was absolutely blown away when I realized that ACE2 was the receptor for the SARS-CoV virus, and also now, of course, for SARS-CoV-2. I had no idea that ACE2 was expressed on the surface of respiratory epithelium. And it is. So what happens there? Well, it actually physically binds the spike protein of the coat of the SARS-CoV and the SARS-CoV-2 virus. ACE2 does, and this has actually been resolved at an atomic scale. Why is this interesting, and what might it have to do with the actual function of the heart? Here, it's fairly conjectural, and bear with me because this is a very tangential argument. But the recognition is that if you knock out ACE2 in otherwise normal mice, this is just a regular knockout mouse experiment, they develop poor LV function. Okay, this is an observation that is old, from 2002. And then you pair that with the fact that SARS-CoV infection, and more recently it's been shown also for CoV-2, lowers the expression of ACE2. So then you put those two together, and maybe it's compatible with the notion that the SARS-CoV viruses inhibit ACE2 and thereby depress LV function. But there's really no corollary data in humans or with SARS-CoV-2. And there's really not that much data implicating contractile dysfunction in COVID anyway. I'll allude to that later. What about the whole controversy about renin-angiotensin system antagonists in COVID? Well, in animal models, ACE inhibitors and angiotensin receptor blockers have been shown to increase ACE2 expression. And so it's been speculated, well, it's quite theoretical, that this increases the risk of SARS-CoV-2 infection simply by having more docking sites. But the role of ACE inhibitors and ARBs in COVID-19 patients is quite uncertain. And there's actually some data that's emerging now that higher ACE2 levels may actually be protective. It's conjectural, but ACE2 levels, for example, decrease naturally with aging. And women have 2 copies of the ACE2 gene, and tend to be less susceptible than men who only have one copy because this is an X-linked gene. But again, these associations remain somewhat conjectural. Among the various heart associations representing Europe and the USA, the recommendation right now is to continue renin-angiotensin system antagonists in patients who are well controlled on their current prescriptions. There's even some preliminary clinical data that imply that maybe these agents are somehow lessen the morbidity of COVID, but this is very, very recent and very preliminary, and I'm not sure you can hang your hat on it, but certainly nothing in the literature that, other than theory, that would imply otherwise. What about cardiac involvement and how does it manifest with COVID? Well, it's been argued on the basis of the Chinese data more than anything else that many of the deaths are related to the heart. In this pie chart from one of the early Chinese series, a full 33% of the cases were attributed solely to the heart in terms of mortality, and another 7% were cardiorespiratory, for a full 40% in which the heart is implicated as a cause of death. But whether or not this is really heart disease or whether it's just a biomarker of systemic inflammation remains somewhat uncertain. We do know for sure that patients who die have, for example, high biomarkers associated with ischemic injuries such as troponin I and troponin T, and having a persistently high and ever increasing troponin I is clearly not a good thing. It's associated with non-survival. If you actually look and do a regression analysis on the risk factors to try to see what's prognostic, cardiac injury is one of the higher associations. Well, there's really no question that myocardial injury, at least as seen by biomarkers, is quite prevalent, but the mechanism remains unclear. In the various epidemiologic series, the number of patients with elevated biomarkers ranges from about 20 to almost 40%. Now, how might that happen? Well, one is sort of a bystander phenomenon in which the immunopathology and the hyperinflammation affect the heart among other organs and lead to biomarkers of injury, arrhythmias, maybe sometimes acute coronary syndromes, I'll talk about that, and different forms of heart failure, either with preserved ejection fraction or reduced ejection fraction. There's also the possibility of direct myocardial injury due to infection by the virus. And finally, of course, the secondary effects of systemic hypoxemia on the heart, which are well known to the listeners here on this webinar. So what about immunopathology, and what do we actually know about what's happening to the tissue in COVID? Well, there are several case reports of fatal myocarditis, and different kinds of inflammatory infiltrates are seen with cardiomyocyte necrosis. And here's some cases, but the true incidence is really unknown, and fulminant myocarditis that's actually fatal seems to be quite rare. In these cases, there was no evidence of direct viral infection, but in a very recent case from Italy, in an endomyocardial biopsy, there was evidence by electron microscopy of viral particles within the heart. So this can happen, and this kind of yes or no, sometimes it happens, but rarely, or maybe in some cases there's direct infection, is also very compatible with what we know about the SARS-CoV epidemic from 2003. What's the role of blood pressure in all this? Well, when we first learned about COVID in the larger case series, there was this paradoxical association of hypertension in patients who went on to require ICU care. At the time of admission, they had a higher blood pressure than the average patient who was admitted, But of course, this turns out not to be the case always, because we tend to see the more classic presentation of critically ill patients requiring vasopressors and having hypotension. So this remains an isolated observation that remains to be validated. Is there a risk of acute myocardial infarction or acute coronary syndromes in COVID-19? Well, there's every reason to believe that there might be, but a paucity of clinical data that in fact it happens. One of the reasons that one might think that it's likely to occur is that there's a general disseminated intravascular coagulation picture, sort of a hyperthrombotic state in the body, as reported by D-dimer elevations, for example, which again distinguish survivors from non-survivors and are quite common in the critically ill. And we know from decades of work that there is a relationship between inflammation and thrombosis. I won't really belabor the point other than to note that endothelial and smooth muscle cells are activated, as are macrophages, and tissue factor expression occurs in atheromatous plaque. And platelets are activated with additional production of pro-inflammatory mediators. In previous viral epidemics of influenza, RSV, and other viruses, there has been an increased incidence ratio of acute myocardial infarction within 7 days of clinical presentation, ranging from about 2 to 10. But the true incidence of acute coronary syndromes and acute myocardial infarction in COVID-19 is currently unknown. One thing that is clear, though, that if we look at what's happening in our hospitals, and I'd be curious to hear from the clinicians later on in the Q&A period, if you're seeing this in the Asia Pacific region, is a sharp decrease in overall presentations to our emergency rooms for acute coronary syndromes and myocardial infarction. In this paper, which just came out today in the Journal of the American College of Cardiology, we see a trend towards decreased activations of teams for ST elevation myocardial infarctions in the months since COVID started. And really, the first month where COVID hit hard in the United States was March. This was seen also in Spain. And here's a very simple plot from the National Health Service in England, just plotting the daily number of emergency department visits for cardiac patients. And you can see a sharp drop in March. Presumably a lot of this is related to acute coronary syndromes having lessened. I personally think that a lot of this is that people would rather suffer at home than risk getting infected. But it's quite possible that there's something more interesting biologically going on, some bystander effect of the virus, or more likely behavioral changes that have modified either risk factors or acute thrombotic episodes in some way among those who don't have the disease. What about arrhythmias? They've been described, and they can be tachy, or even asystole, but the description of such arrhythmias is very vague to date. Palpitations are described in 7% of patients in one of these first series from Wuhan. And in this admission EKG of a 31-year-old patient with multi-system failure, who parenthetically went on to recover, his admission electrocardiogram was just a sinus tach. VT and VF are quite rare in patients with COVID, but it's said that they occur. And in a very general sense, arrhythmia is seen, and there's some difference between those who require the ICU, who have more arrhythmias, of course, than those who are not in the intensive care unit. And the whole arrhythmia thing is actually made worse by the fact that, at least in the United States, many of the patients are getting treated off-label with antimalarials. I'll talk to you about that in a second. But before doing so, it should be noted that there's some interest now in using antibodies against IL-6 or IL-6 receptor, and there are several case reports of dramatic improvement in critically ill patients who get such antibodies, presumably because they're attacking the cytokine storm and the hyperinflammation. But the whole thing with hydroxychloroquine and or azithromycin is rooted in some in vitro data that showed that SARS-CoV-2 replication is inhibited. That goes back just to February. And then in March, there was a randomized clinical trial of only 30 patients that really showed no benefit between hydroxychloroquine and control groups. But things got muddied in March 20th by a very spectacular paper that claimed on the basis of just 6 patients measuring viral loads. This is from Marseille in France. It's been roundly criticized since then, but has been very impactful, that these patients cleared on dual therapy, cleared their virus more quickly than patients who were either treated only with hydroxychloroquine or not treated at all. This study then, this same center, Marseille, published a series that showed an improvement in length of stay and contagiousness, but no comparison group. And finally, there was a Chinese randomized clinical trial that tended to show a shorter time to clinical recovery in the hydroxychloroquine group, but an increase in adverse effects. And one of the adverse effects that we're quite worried about is we know these antimalarials prolong the QT interval of the electrocardiogram and delay cardiac repolarization, thereby predisposing to polymorphic ventricular tachycardia, also known as torsade de pointe. And in a recent preprint from the experience at a major medical center in New York, the QT was increased to more than 500 milliseconds in a full 11% of patients who were given the combination of hydroxychloroquine and azithromycin. Whether or not this leads to arrhythmias is not completely clear, but we do know that one study of hydroxychloroquine with azithromycin was recently terminated prematurely because of a higher incidence of malignant arrhythmias. What about antivirals? Well, there was a nicely conducted placebo-controlled trial of this anti-HIV cocktail, lopinavir and ritonavir, that was published about a month ago in the New England Journal, showing really no difference between placebo and the combination drug. And more recently, this drug remdesivir that's a nucleoside analog that was developed for Ebola, but never had much efficacy in Ebola, or didn't have much chance to be tested. I would say it's not necessarily as inert, has gotten a lot of currency and is now in randomized clinical trials. But just a few days ago in the New England Journal, they published a series of compassionate use cases, and a bunch of the patients fully or showed clinical improvement, which varied according to age. But in many medical centers, these sorts of trends for clinical improvement would not necessarily be out of the norm. So since there was no control group there, I think it's easy to overinterpret this, and we await a proper randomized clinical trial. What about corticosteroids? They're used frequently, but we should bear in mind that at least in previous viral epidemics, both with coronaviruses, the MERS epidemic, as well as the SARS epidemic, there were really no indications of efficacy associated with the use of corticosteroids or better outcomes, but there were a number of complications. And this has also been true in previous epidemics with influenza and respiratory syncytial virus. So nothing is known yet about COVID, but there's every reason to expect that corticosteroids are not going to be standard of care. What about cell therapy? Well, there's some interest in the literature, a total of only, I think, 9 patients in China who were treated with some kind of bone marrow mesenchymal stem cell, and they claimed quite remarkable recoveries. These are not yet any peer-reviewed journals. They're on the preprint servers. But independent of those reports, we put 2 and 2 together and wondered whether the cell type that we've been interested in for a while, the cardiosphere-derived cells, might be useful in COVID-19. These are cells that are isolated from the human heart using a fairly simple explant method that was described, that we described in the literature back in 2007 in Circulation. You start with a little bit of human heart tissue and end up with the CDCs after going through several plating steps and no antigenic selection. We conceive of these cells as cardiac progenitors in the sense that they have multi-lineage potential in vitro, but they don't seem to do that, or they don't seem to work that way anyway in vivo. They just seem to function as cardiac stromal cells that secrete very bioactive extracellular vesicles that go on to mediate cardiomyogenesis, angiogenesis, antifibrotic effects. But for the purposes of COVID, they're very immunomodulatory, anti-inflammatory, and they promote cardiomyocyte survival. Everything the doctor ordered really in what you've seen about the pathophysiology of COVID. And now these cells have been in more than 200 patients worldwide in various clinical trials for myocardial infarction, for heart failure with reduced ejection fraction, Duchenne muscular dystrophy, and there's 2 ongoing trials for pulmonary hypertension and for heart failure with preserved ejection fraction. They have a proven safety record and overall some evidence of disease-modifying bioactivity. And when you look at what's known about the SARS-CoV-2 virus and how it leads to systemic inflammation and multi-organ dysfunction, regulatory T cells are involved, and as they're depressed, the situation gets worse. They interact with effector T cells and macrophages to produce cytokine elevations. And at every one of these node points, we have evidence that there's bioactivity of CDCs or their exosomes that's in the correct direction to mitigate the systemic inflammation and the multi-organ dysfunction. Among the clinical trials that have been done, the indication for Duchenne muscular dystrophy is the furthest along and has undergone a randomized and placebo-controlled trial, which shows after an interim analysis has been reported to show quite dramatic benefits in terms of stabilization of the skeletal muscle dysfunction, as well as improvements in heart function in the young men and boys who got the intravenous cells. So what do we know specifically about how they might interact with lymphocytopenia, for example? Well, we've discovered that in terms of the cytokine storm, there's a decrease in IL-6 in animals with aging-related heart failure, preserved ejection fraction, and systemic inflammation, as well as in IL-1, which is IL-1B, which is another biomarker of systemic inflammation. And we, in unpublished work from the lab, we've discovered that there's an increase in the proliferation of regulatory T cells, the beneficial immunomodulatory T cells, when exposed to the exosomes secreted by CDCs. Not only do they increase the proliferation of regulatory T cells, but they also activate the regulatory T cells so that they produce more of the beneficial anti-inflammatory cytokine IL-10. And in a model of experimental autoimmune myocarditis, the exosomes from CDCs increase ejection fraction, decrease the QT interval, and decrease the amount of inflammation within the heart. These are all unpublished data from Shah Akhmerov in my lab. So altogether, this has now led to what we call the CS-cubed trial, an acronym for CDCs, for cytokine storm, and COVID syndrome. And right now, this is a compassionate use protocol. We've enrolled 5 patients to date. These patients have confirmed COVID-19 and they're critically ill. With some, in general, they've all had severe respiratory failure and been intubated, lymphocytopenia, and some elevation of inflammatory biomarkers. And the intervention here has been open label intravenous CAP1002. That's the corporate name for allogeneic CDCs. If they're given once, and if the patient is still sick a week later, they can also get a second dose that's based on the clinical course. So far, only 1 out of the 5 patients has gotten a second dose. The first 3 patients have done quite well, and the last 2 patients have just recently been enrolled, but so it's too early to see what their clinical course is like, but they're certainly still alive, I'm happy to report. The exploratory outcomes, of course, are mortality, the length of the ICU stay, escalation of support, and we're looking at biomarkers of all sorts. This is by way of ushering in, if these data look promising, a randomized placebo-controlled clinical trial, which we've already designed and are hoping to get initiated within weeks after we get regulatory approval to do so. Finally, are there long-term sequelae? Well, not much is known about COVID because there are no long-term survivors by definition. The epidemic really just began in the fall in Wuhan. But we do know from the SARS-CoV epidemic that there are several phases. There's, of course, the acute phase. There's a convalescent phase, which here I arbitrarily signal is between, let's say, 21 days and several months when the patient is recently been ill. And then there's the chronic phase from months to years. And based on the, we know, of course, from what I've shown you, that there's acute respiratory distress syndrome and myocarditis sometimes in the acute phase. But there are some cases from the SARS-CoV literature, and maybe one case report so far from the COVID literature of a delayed myocarditis after the patient was apparently better clinically. And isolated cases, some by hearsay and a couple in the literature, of asystolic cardiac arrest after the patient appeared to be getting better. And then from the SARS-CoV experience, there's long-term complications, including hyperlipidemia, some reports of hypertension, and also perhaps long-term pulmonary fibrosis. So these things are obviously things to look out for in COVID survivors, and may or may not be related to the extent of disease severity upon presentation, but I'd be surprised if they weren't. So I'd like to finish by just reminding you that immune overreaction is bad and is associated with mortality, that the role of ACE2, other than binding the virus, is somewhat vague. Cardiac involvement is prominent, at least at the biomarker level. It's extremely common. How that manifests clinically is somewhat less known, and probably is overstated in a lot of the literature in terms of how important a problem, for example, fulminant myocarditis might be, acute coronary syndrome might be, or arrhythmias might be in the setting of disease. At least that's our experience so far based on about 400 patients at my medical center. In terms of therapeutics, there's very little by way of evidence-based medicine, but several randomized placebo-controlled trials are underway. And we don't know anything really about the long-term sequelae, but it's something to look out for. I'd like to just finish by acknowledging the work of my fellow Shah Akhmarov, who helped me with the slides and who's the co-author on the recent Circ research paper. And he's a member of sort of a mini COVID task force within my lab that also includes Ahmed Ibrahim, Jeff DeCuto, and Russell Rogers. My clinical collaborator in the CS Cube trial is Raj Makar, who was also the principal investigator on a couple of the earlier CDC studies involving interventional procedures to deliver the drug, the cells. And we've gotten funding from various agencies stateside. This is what my professional home looks like. for dramatic effect. It was caught on a very rare cloudy day in Los Angeles. This is the medical center, and this is an aerial view of the home of the Heart Institute. All right, well, I'm going to stop sharing my screen, and we can probably do some questions.
Fantastic. That was a really highly informative talk, Prof. Marban, and we will open up to questions. Fantastic presentation. I might start it off with some of the presentations. We've had a lot of questions posed on our chat forum, so everyone is welcome to still put some more chat questions up, or you can raise your hands as well. You can do that by clicking on your participant button, and there's a little raise hand icon there. So Prof. Marban and also our panelists, a few of the questions were surrounding the inflammatory response, both in terms of interleukin-6 signaling and also the cytokine storm. How much of this is just it being an innocent bystander versus actually contributing a lot to the disease state?
Well, the best evidence that, most of the evidence linking it to mortality is associational. Patients who die or who have ICU admission have higher levels of these biomarkers. But so far, the evidence implying that you can intervene on that as a therapeutic target and make people better is quite limited. There are some very dramatic reports of people getting better quickly on anti-IL-6 or anti-IL-6 receptor antibodies, and these are now being subjected to clinical trials. But really, other than association, there's a rather limited evidence base for therapeutic intervention.
Did you want to comment, follow up on that question further, Gemma?
No, I mean, I think it's obvious in terms of what the next steps would have to be for that, but I appreciate your thoughts on it.
So in terms of another question, we've spoken a bit about, and you touched very briefly on the gender differences. So you mentioned that ACE2 receptors are on the X chromosome, and it could explain why we are seeing lower rates of infection and severity in women. Is there pretty robust data on that sex difference?
There are robust data on this. At least we've got a paper that is just been submitted. It's not on a preprint server, but it's the experience of over 400 cases at my medical center, carefully curated study in the sense that we have, very good phenotyping on all these patients, and there's an enormous difference, at least in the severity of the illness in men relative to women, more than 3-to-1 ratio in terms of severe cases. There doesn't seem to be any evidence for a decrease or a difference in infection or infectability, but there does seem to be a very strong difference in disease severity. And this is consistent with what's been published in China and in Washington State as well. And I think in Italy, although they've been so overwhelmed, they haven't published as much as some of the other centers. But what we're seeing from Spain and from Italy is certainly consistent with that.
Great. And maybe just opening out to our panelists as well, just to touch a little bit on troponin levels and ACS in COVID-19. So we know, and you've presented some data, troponin levels are elevated. I know the ACC put out a statement saying that perhaps we shouldn't measure troponin in these patients. Maybe, Prof. Marban, you can comment on what your practices are, and then we'll open out to some other of our cardiologists.
Well, we measure it, but we measure the troponin I as part of our COVID panel, but we measure it really more of a biomarker of inflammation than we do as a signal that we have to go in there and do an echocardiogram or intervene. Doing an echocardiogram in patients who are critically ill with COVID is non-trivial. There's the PPE, that's the personal protective equipment that's consumed. A patient that's often, one of the therapeutic interventions that we have for intubated patients that seems to be the most effective is to prone them. So they're turned upside down in bed and intubated, and you can't get a good echo that way. So this is the PPE and everything else makes it really hard to get an echo and puts the echocardiographers at significant risk of contagion. So I think one of the reasons not to measure it is that you shouldn't be fooled into automatically thinking that there's an acute coronary syndrome. But we measure it really just for disease progression purposes, and but it's controversial. I can't tell you that it's clinically valuable. It's just something that we are looking at really to increase our knowledge base.
And Ravi, I'm not sure, or Aaron, could you comment on what your practices will be?
Thanks, Sarah. Look, as Professor Marban says, I think the main utility is more from as a prognostic tool. I think the hazards of then reacting and doing other tests are probably not indicated. So I think, from a panel point of view, we would measure it to try and give guidance in terms of the trajectory of the patient. But our decision to intervene or investigate a troponin rise would be driven by the clinical picture.
Yeah, I completely agree with Professor Marban and with Ravi. We would measure it, but in terms of actually acting on it, there would have to be ST elevation or something else there in patient's presentation to lead to further intervention.
I guess the difficulty is that a lot of these patients have concurrent myocarditis and they'll have high troponins, they'll have ECG changes. What about use of aspirin, use of anticoagulants? Obviously, these patients are also hypercoagulable. I know a lot of doctors in New York are giving aspirin to these patients, and they are often given heparin or Clexane. Prof. Marban, could you comment on that, or anyone else want to weigh in?
Well, it makes sense given what we know about, especially if you can document elevated D-dimers in these patients. It would make sense to anticoagulate them systemically. The line of thinking has gone even as far in one of the hospitals in New York as to give patients thrombolytic agents, not patients who are having a myocardial infarction, just patients who are severely ill. The reasoning being that perhaps they have thrombotic events throughout the body. And I don't know, it's not been reported except in the popular press, but 2 of those patients died. So out of 5. So maybe it's doing something, maybe it's not. So.
Can I weigh in? It's Jason from the Victor Chang. I think a lot of you know I just came back from Mount Sinai in New York. I'm still actually faculty there. A couple of my old patients have unfortunately died. I've still got one in the ICU. And the guy in the ICU actually had a PE who was actually seen on echo, so they never needed a CT, but they actually saw a clot in transit as they were echoing him. And Sinai has now adopted a fairly, not thrombolysis, but a fairly aggressive anticoagulation protocol that involves anyone who's in the ICU with any high-risk features like a high D-dimer, high oxygen, etc. They're being systemically anticoagulated with IV heparin, and others, they're having a low threshold to also anticoagulate. So I think this, Eduardo, I know you said it was DIC. I'm not sure, a DIC-like picture. I'm not sure I fully agree with that, because DIC has often features of bleeding, and we haven't seen a lot of bleeding problems. Low platelets and a prolonged APTT is also some of the features of a DIC, and it's not really that kind of picture. It's more a sort of micro, even macro thrombosis, and I've wondered whether the high troponins is actually related to some kind of slow coronary flow situation related to this thrombosis. But I think this is a real emerging story with COVID-19, and Sinai's been quite aggressive in terms of anticoagulation. I think it's actually been fairly effective, but I don't think it's Sinai that's been doing thrombolysis.
So I agree that it's not DIC, and we very rarely see a classical DIC syndrome, but one often thinks of it when you see D-dimers, but obviously the rest of the picture isn't there.
Yeah, I agree. Yeah,
Jason,
go ahead.
Just following up on that, given this profound hypoxia that people are getting, is there any evidence that actually some of the thrombophilic predisposition is actually impacting the microvessels in the lungs as well? Not necessarily big clot load, but actually,
right.
actually forming in situ.
Look, it's really subjective, and there is a sort of gestalt going through Sinai at the moment. So Sinai is like 8 hospitals. I think across 8 hospitals, as of today, there's 2,000 inpatients, 420 patients on ventilators, and there's a sense at Sinai that there is some sort of slow microvascular flow. Another feature, I'm not sure, Eduardo, if this has been published, it may have been, but there seems to be a very pervasive delirium that comes with COVID-19. And whilst a lot of ICU patients get this sort of ICU delirium, it's actually a across the board feature that delirium is substantial and early in COVID-19. And they're wondering, just like you were saying, Gemma, about microcirculation in the lung, whether that's actually a microcirculation in the brain thing, which is contributing to the pervasive delirium which is being seen. So I do wonder about that, but the sort of counter against that is that we're not seeing lots of like digital ischemia and those sorts of things you might expect to see if that was part of it. So it's a very interesting emerging thing with COVID-19.
Sarah, if I'm allowed to put my hand up for one more question. Prof Marban, I'd be really interested in terms of if you see promising results with your cardiac spheroid-generated exosomes, what's the opportunity for upscaling, and how can you do that in a safe and effective manner? And I guess more importantly, in terms of long-term, what can we do as a community of cardiovascular researchers to better integrate into the health system and get such translation happening?
Well, the manufacturing so far first of all, we're using the cells, not the exosomes, although the exosomes may be a next generation cell-free product. We actually are quite interested in that and doing in vitro work actually to see if the exosomes alter infection in vitro. But the cells have been made and are banked at sort of clinical trial scale. So there's hundreds of doses that are ready, and that's why we decided to go with the cells. The company that's licensed the technology was previously developing them more for Duchenne muscular dystrophy because that's furthest along. And they have a plan for upscaling the manufacturing that involves technology transfer to a large-scale professional cell manufacturing company, so they could do many tens of thousands of doses. I don't know. I mean, the timetable for that upscaling probably would jive fairly well with demonstration of efficacy in a randomized clinical trial in the sense that it had already started for the Duchenne program. But was there a second part to your question that I didn't address?
Oh, it was a bit more around how we actually get better as a research sector at being able to upscale things on demand and be better integrated into the health challenges that we're facing, both acutely as well as subacutely, I guess.
Yeah, well, we as academics or academic physicians are not particularly good at that. We're really good at thinking of ideas and testing hypotheses and maybe doing proof of concept studies. But at some point, there needs to be commercial involvement in people who actually want to make a product, or not want to, but know how to make a product. So that chasm is not always easy to bridge. We've been fairly lucky because the company that was started on my technology has been pretty faithful at developing it and fortuitously in terms of timing. But it took a lot of work to do that. It wasn't something that just happened. So I think basically being sure that your ideas don't lie fallow, that you generate intellectual property when you can, that you develop good relationships with industry, and I think one thing that's very important is to be in a medical center that values entrepreneurial activity and spin-offs, and that varies tremendously, at least in the United States, from place to place. How easy that is. It happens to be pretty easy in part of the ethos where I am, but there's other places where there's a lot of worry about conflict of interest, and so much that it stymies any possibility of actually doing translation. So.
Thanks for that. Now, just to change tack a little bit, going back to an earlier question from Anastasia. So there's been a lot of media hype and a lot of doctors actually reporting on this, that zinc and zinc lozenges can actually prevent infection and severity. Is this all media hype, or is this something real? Can you comment on that, Prof. Marban?
Well, yeah, one of my friends sent me an article from a chiropractor in Florida claiming that COVID is a curable disease with zinc and something else. I forget what it was.
Salty water, perhaps.
Yeah, I mean, the only kind of ironic thing that I can think of is that the one thing that zinc is known to do is to cause anosmia, and for some reason, the patients early on in the course of the infection get anosmia. But unless it's one of these situations where a little hair of the dog will cure you, the hair of the dog that bit you, I don't think it's going to do much. At least there's no theoretical basis that I can think of. Do any of the panelists have reason to believe that zinc might be good?
I can briefly butt in there because I quite like zinc lozenges, but they do actually apparently decrease other coronavirus RNA transcription, and particularly in the early phase when people are getting sore throats related to other coronaviruses, that apparently improves the symptoms by about 50%, and apparently also reduces the length of symptoms by about 50%. But these are the other, non-COVID-19. So I think it's really just obviously needs further investigation. And I think systemic zinc's actually probably not got as much evidence as actually the topical throat stuff.
And so just to move to another question, thanks, Gemma. We've had a couple of questions about obesity and both the severity of the disease and also the long-term outcomes for this. Is there effect of obesity on ICU admissions? Is this purely mechanical, or is it something metabolic?
I don't know what you've seen in your region, but we have been struck by the association between obesity and worsening disease, especially in the younger population. We don't see too many patients who are lean and intubated with COVID. It also makes it, being obese, of course, makes it harder to take care of the patient because it's harder to prone and all those other things that we're doing in the MICU. But I'd be curious to see whether, and again, in this paper that we've submitted, this is a very strong association with bad outcomes is obesity. But I don't know if you all have seen that either anecdotally or published anywhere in your series.
Tom Mark, did you want to comment on that question further?
Yes, Sarah, thanks. Yeah, this is an interesting association. I have seen it come from other places, the story come from other places, Eduardo. The question, I guess, is whether this is a work of breathing story with visceral adiposity, or whether there's some story here that goes on with inflammation or some combination. I wondered if you had any insights about that.
I don't. I think they're both really good thoughts. And I don't, and getting even more sort of conjectural, is there some association between obesity and the ACE2? I have no idea. But
Andrew Murphy has just put a comment. Would you like to comment for everyone else?
Yeah, I can just make a brief comment. So, we know that people with obesity and diabetes have increased myeloid cells and decreased lymphocytes. So that may put them more at-risk group of not recovering from COVID-19.
Yeah, interesting. Okay, so look, once again, let's just go maybe back to the heart dysfunction issue. So obviously you've touched that it could be myocarditis, it could be direct infection, we're presuming it's mostly inflammatory. What about long-term recovery? Do we have any idea of how quickly this can recover in some patients? Obviously, we've had some who've probably come through, had repeat echoes, maybe at 10 days, maybe at 1 month. Do we know much about that recovery?
Well, we've been impressed by the dissociation between biomarkers and cardiac dysfunction. It's not robust data set because of the fact that we can't easily go in there and and do an echocardiogram. But certainly the presentations.
But once these patients have recovered, and then
yeah. So in the recovery phase, I'm not aware of any literature that implicates COVID as being something that leads to long-term cardiac dysfunction. Even if they've had sizable troponin elevations. There are the case studies that are out there are usually the fulminant myocarditis, but they can be counted on the digits of one hand. So.
That's interesting because that's actually what you see a lot in the literature. So you tend to be quite focused on that aspect. And what about the effect? So you touched very nicely on how we're seeing much lower rates of ACS and even STEMI presenting to hospital. And there was that New York data presented showing this 800% increase in out-of-hospital cardiac arrests. I guess the question in Australia is what's going to be the long-term effects on all our cardiovascular patients? Maybe Garry Jennings from the Heart Foundation could comment a little bit on what they're doing to try and prevent some of these downstream effects.
Well, what we're doing and what heart associations worldwide are doing are trying to encourage people to present when they do have a change in symptoms. But clearly, there's a reluctance in the community, and of course, there was also reported from New York a much higher rate of out-of-hospital deaths, many of which are presumably cardiac too. I think we have to be very cognizant of the possibility that the indirect consequences of COVID on the health system, particularly care for people with chronic disease and delays and things might match the direct if we're not cognizant of the needs that people still having strokes, still having STEMIs. I doubt very much, as Eduardo said, that there are fewer STEMIs. I think they're just not coming along.
And then eventually we're going to see these patients present, but maybe days later with poorer EFs and long-term effects of that.
That's right.
One thing that it doesn't really address your question directly, which is more at the address of the population, but it is notable to me how infrequently there seem to be acute coronary syndromes within patients with confirmed COVID that are severely ill and that have every right to have, a prothrombotic state. And I find that interesting biologically. Why is that? Is there something kind of weirdly protective about the infection that we don't yet recognize when everything that we know about it would make us think that it would be just the perfect recipe for an ACS? A lot of the activations of the cath lab in patients with COVID turn out to be for something, myocarditis or something that clean vessels and ST elevations and high troponins.
And of course, surely there's a high incidence of Takotsubo's that we're going to start seeing as well.
We haven't seen that, but it's something that wouldn't surprise me on the basis of, first principles.
It's certainly been reported, but it tends to be an early thing rather than the later cardiac manifestations that you describe.
So going back to the actual immune system and why we're seeing all these differences in susceptibility and severity of infection, so differences between genders, obviously a clear difference between children versus adults as well. Livia, do you want to maybe comment on this first? You brought this up as a question and then we'll get the panelists to also comment.
Yes, thanks for that. Yeah, we know that children have a high expression of ACE2 protein in their lungs, but we think that there's a relationship between the way ACE2 is also interacting with the immune system. But do you have any comments about that, Prof. Marban? And what makes them protected?
Olivia, one of the more striking things in terms of recognition of the relationship between ACE levels and disease severity is that there seems to be a general association between low ACE2 levels and disease severity. Low ACE2 levels not in the course of the disease, but in the course of whatever, aging or gender or anything else that we know affects, or for that matter, probably even the directional effects of the ACE inhibitors and the ARBs so far is actually to, when it's been reported, is to mitigate the disease, not to worsen it, and they tend to increase ACE2 expression levels. And so what is it about ACE2 that might, I mean, one hypothesis has been put forth recently in JAMA Cardiology, and it's just sort of an idea, is that ACE2 overexpression of ACE2 might increase the predilection to infection, but thereafter, for whatever biological reason, and there's a lot of conjecture about this, but really not that much science, would be mitigating the disease illness. And so, but I'd love to hear, there must be somebody on the panel that knows more about ACE2 than I do. So I'd love to hear anybody's perspective if they're particularly interested in that aspect of the science.
Do you want to comment further, Livia or Nathan? Any thoughts on that?
Just while you're thinking, there are trials underway of recombinant ACE2 in this situation too. So certainly some people are impressed by the theory, if not the science, that there might be mitigating benefits.
Yeah.
One thing that we have seen, and again, this is sort of at the level of anecdote, but one thing that we seem to be seeing at our medical center is that young patients come in, mild symptoms, have astronomically high levels of high viral loads. And so maybe there is some truth to the general idea that, yeah, they get infected, but they're somehow less protected from disease. So.
And Nathan, you made a really good comment before in terms of what the opportunities are for researchers to contribute productively to everything that's going on COVID-19 at the moment. I mean, I kind of agree with your comment, Nathan, that there is a lot of preprint publications getting out there prior to peer review, and we really do need to focus on certain research groups achieving, what we want to achieve, rather than, like you touched on, Prof. Marban, we need good RCTs rather than all this early reporting of quite observational data. Nathan, do you want to expand on that a bit further?
Yeah, I just thought, we have a download of a lot of information, and Professor Marban, you've done a beautiful job of distilling a lot of information coming through publications and preprints. And I just wondered if you could give some suggestions within that interface of fundamental researchers and clinical groups of how to orient our questions a bit productively. If we were to just focus on the cardiovascular complications, what would you suggest we might want to focus attention on at this point?
Are you asking in the context of preprint servers per se, or just as a general science question?
No, it's just a general science question. I think the challenge here is that, at each of our institutions, I think there's a lot of discussion around getting involved in the COVID discovery process. But again, the challenge there is actually how to identify questions that allow us to really contribute something substantially in that space. So I just wondered, from your experience and your engagement within the sector at this point, if you have advice around how we as a research community can be involved in that process through a productive dialogue between the clinical groups and the research groups.
One thing that's stymieing research in the United States anyway, and I suspect this is an issue in Australia and New Zealand as well, is the fact that we need a biosafety level 3 facility to work with the SARS-CoV-2 virus. And they're not all that common here in the US. So let's say you have some question about interactions between the virus and cardiomyocytes, the virus and endothelial cells, or something that's biologically testable. It's hard to actually test that without a biosafety level 3 facility. And even then, handling the tissues that come out of that facility for processing, you need to be careful. It's not a trivial handoff. We ourselves, in our studies of certain things and how they interact with the infection process. Exosomes, for example, have had to collaborate with a university that has a BSL-3 facility. And of course, they've got a queue of hundreds of people. And so we were lucky to be able to convince them that our experiments were pretty focused and had merit. So if you have a BSL-3 facility, I'd go to town and do everything you can with actually the virus and whatever cells of interest you can, and then measure downstream. So little is known that even low-hanging fruit with things like RNA sequencing and ChIP-seq and all the things we can do now. What does this actually do to the target cells when they're involved? Short of that, I think the kinds of things that we need to be focusing on have to do with mechanisms of inflammation and macrophage activation and cytokine production, and how these things not only get produced, but also how they impact the cardiovascular system. There's a lot of ACE2 biology, fundamental biology. I don't know if anybody has a clue. I certainly have no clue at all why ACE2 is in the lung surface to begin with. I mean, I always thought of it as an intracellular enzyme that was converting one thing to another. But so even simple, I mean, that's a teleological question. It's not one that's easy to answer using the kinds of experimental techniques that we have. But still, I think there's this whole question of ACE2 biology and how it interacts with and how it's interacted by the virus that is quite interesting. So.
That's great. Thank you. Now, just going to a question from David Berger. So he's quite interested in the comment that you actually saw lower rates of ACS in your COVID-infected patients. Is that actually quantitative data that we've got on that?
No, it's not. It's an impression. But at least in the literature that I quoted from influenza and RSV and the SARS-CoV epidemic, the first SARS epidemic, there was data that within 7 days of the acute hospitalization, there was an increased risk of MI and ACS. And we don't seem to be seeing that in our population. And I don't know what you're seeing, what you're hearing about Mount Sinai, but it does not seem like we're sitting on a bunch of patients who are manifesting unstable angina or acute myocardial infarction. And a lot of our trips to the cath lab, not a lot of our trips, there have been very few of them, but at least some of our trips to the cath lab for patients who really seem to have the Jenny article have ended up being non-ischemic or non-epicardial artery ischemic.
Yeah,
but it's quantitative. I think it has to be quantified.
It's been the same experience at Mount Sinai, very similar.
I mean, our cath lab's quite deserted at Monash Heart. I'm not sure what it's like at North Shore or elsewhere. Ravi, if you wanted to comment.
I could, go Rav.
So at North Shore, I think as is most of Australia, we're at a different part of our curve compared to our friends and colleagues in the US or Europe. And part of the reason why we're empty like you, Sarah, is because we've cancelled elective activity. Certainly our case volumes in terms of ACS, whilst there's a drop in numbers, I can't say for sure that we've noticed the big drops that have been described in Europe and the United States. And that might, as I said, reflect where we're up to in our infection rate in the community here.
This is just an editorial comment, but we made storage plans for up to 1,000 COVID patients, and we've never, thank goodness, but we've never had more than 120 at a time. We implemented social distancing early and so on, and so that scenario may or may not play out in each of your hospitals.
Yeah. Okay. Look, I might move on to a combined last question, and anyone feel free to comment. What about, I guess we're looking at the long term, how are we going to, what's the end game here? what about wide-scale serology testing? And is there the possibility of reinfection, or can we talk about this immunity even prior to talking about a vaccine? So serology testing, is it useful, and are we going to achieve an immunity without getting the reinfection that has been reported?
Well, what we know so far is that in survivors of COVID, there's a typical IgM, IgG response. And I didn't mention it, but you all are very well aware of the fact that convalescent plasma is one of the things that is being used to treat patients now. Whether or not it works, there's a very small case series that makes you think that it might, but the rationale there is, of course, that if survivors have good antibodies, it might help clear the virus during infection. We don't know if such immunity is present in everyone that's durable. There do seem to be low titers in some people that may or may not guard against reinfection. This is just an emerging biology. It's also not clear if we're going to have lasting infection, as we would, for example, from a smallpox vaccine, or whether it's going to be, a briefer coverage of, against reinfection.
And anyone else from our panel, Livia or Nathan, Garry, anyone else want to weigh in on this comment of reinfection, serology? Are we going to have a second peak for this pandemic that's worse than the first? What are people's thoughts?
Well, whether or not we have a second peak depends on how well we handle the easing off the restrictions that are presently there, and unfortunately we're learning as we're going. It's very disappointing, some of that very early data from Korea suggesting that not everybody is immune following it, and of course that's going to be critical in determining what happens from now on.
Yeah, although Sarah, in Australia, obviously we're lucky enough that actually immunity in itself is going to be so low, hopefully, and just completely, we're in a very different situation. But even in New York, they think, in a cross section that just was done the other day, I think 1% of people are positive. So I think the catastrophe is when we get inundated in the ICU, but I think it's probably giving an over emphasis on actually what the community incidence is, and I think getting to a point where we've got herd immunity is a long way off.
Yeah, I agree with that. We won't get that. We won't see that in Australia. I mean, our advantage is being an island, I think, and being isolated, and that's really kept our immunity. It's kept our infection levels down, but equally our herd immunity also will be decreased. Yeah.
Fantastic. Yeah.
Sarah, I might
wrap it up there and hand over back to Kate or Gemma, whoever's going to close.
Well, I was actually going to say thank you to both of you guys for doing such a terrific job at organising this, and then obviously hosting such a terrific discussion. I think adaptation to webinar kind of situation and Zooms is something that we're all getting a little bit better on, and it gives us the opportunity of reaching into Prof Marban's kitchen and maybe getting him ready for a whiskey or something by the look of it there, Eduardo. Look, we really, really appreciate it. I think this is going to be the first of a number of webinar series that we'll have between the Australian Cardiovascular Alliance and the International Society for Heart Research, and I think it's really been an absolutely fabulous start and had huge engagement. I think there's over 200 people have signed in over that time, and some terrific questions. So thanks again, and thanks to our panel members, and we wish you the best of an Easter Monday over your way, Eduardo. And thanks also to our Asian and Pacific kind of ring-ins as well in this time zone. I think we certainly encourage you to reach out to more of your colleagues for future ones. So terrific. See you later, everybody, and have a great Tuesday in our time zone.
Thanks, Gemma. And just to finish off, I have actually just posted the links to the YouTube channel for the ISHR Cardiovascular Seminar Series in the chat box. and also the program of upcoming talks. And as Gemma mentioned, we are in the process of setting up a seminar series for cardiovascular researchers in the Asia Pacific region. So stay tuned for more information about that. Thanks, everyone.
Thanks, Kate. Okay. Bye, everybody. Stay safe.